Hello, this is David Wolinsky for the American Society of Nuclear Cardiology and the Referring Wisely program to discuss a case of a 76-year-old female with peripheral vascular disease being seen for preoperative evaluation. This is a 76-year-old female with a history of hypertension, long-standing insulin-dependent diabetes mellitus, and hyperlipidemia. She presented with right leg claudication, and subsequently her endocrinologist referred her for a CTA, which revealed occlusion of the right superficial femoral artery with single vessel runoff. Based on the severity of the vascular disease, she was referred to a vascular surgeon who planned surgery on her and referred the patient for what he called cardiac clearance. Now, the concept of cardiac clearance is always a difficult concept to deal with. We prefer to call it cardiac evaluation. We use this as cardiologists as an opportunity to assess the patient's baseline cardiovascular status, the potential risk of non-cardiac surgery, and assess the need for long-term treatment or management. In this case, the initial database revealed no prior cardiac history or evaluation. Her medications include rosuvastatin, glipizide, amlodipine, and benazepril. Her lab profile showed a cholesterol of 211 with a triglyceride of 193. Her HDL was 51, and despite being on a statin, her LDL was still 121. She complained of severe claudication, including some rest pain. So what evaluation would be appropriate to be carried out as part of her preoperative evaluation? The next slide looks at the algorithms for cardiac imaging based on the appropriate use criterion. And you can see there are three major boxes there. The top one is for preoperative cardiac assessment. The middle one is for prior evaluation or known coronary artery disease. And the third one is no prior cardiac or coronary artery disease. So if we focus on the top box of preoperative cardiac assessment, and we think more about what goes into the basic cardiovascular assessment. Let's now look at the determinants that go into evaluation for preoperative testing. There are really three major factors that go into the initial assessment of cardiovascular risk in these patients. The first is the overall cardiovascular status. What chronic coronary or cardiac disease do they have? Are there acute symptoms? Are there chronic symptoms? Are there long-term issues that have been dealt with or have not been recently dealt with? The second is the nature of the surgery, whether it's low risk, intermediate risk, or high risk. Low-risk surgery is defined by less than 1% mortality. And in these types of patients, rarely is any type of cardiovascular assessment needed. And the third is the patient's functional capacity. How far can they walk? What can they do? What do they do in their daily activities? We'll talk about that more in just a few seconds. These three factors determine the overall risk and determines what testing or evaluation needs to be done down the line. The next slide helps define functional capacity. We talk about metabolic equivalence, or METs of activity, and when we look at preoperative risk assessment, the magic number is 4 METs, that if you can do more than 4 METs of exercise, then you are considered reasonable risk for almost all surgery. And if you can see in this graph here that activities associated with more than 4 METs of functional capacity are being able to climb more than one flight of stairs without stopping, walking 1 to 2 blocks up a hill, scrubbing floors, moving furniture, doing recreational activities such as golf, bowling, dancing, or tennis, or running short distances. This is an important concept to understand, and often these types of questions should be asked to get a best sense of what patients' functional capacity is. We have actually several sets of recommendations that are designed to assess preoperative risk assessment. This comes from the 2014 ACC AHA guidelines on perioperative cardiovascular evaluation and management. And what you can see here is in the diamond towards the bottom of the page, when patients have poor or unknown functional capacity of less than 4 METs, then pharmacologic stress testing is a Class 2A indication to carry out. When we look at the stable ischemic heart disease guidelines, we also have algorithms for assessment of preoperative cardiovascular risk, and that is shown on the next slide. So here we can see the algorithm for preoperative assessment based on the ACC, AHA, ASNC, stable ischemic heart disease guidelines. And you can see there are 5 steps to the algorithm. Step 1 is whether or not the patient needs emergency surgery, and of course in that case you would just proceed to operate. Step 2 is whether the patient has active cardiac conditions, active chest pain, active heart failure, progressive valve disease, in which case you would then follow specific guidelines for that. Step 3 is the patient who has low-risk surgery, and as I said prior, those people could go on to surgery without any significant risk assessment. And step 4 begins to evaluate functional capacity. If the patient has preserved functional capacity, that is, they can do 4 or more METs without symptoms, then one could proceed with surgery. And step 5, which is blown up on the next slide, talks about patients who have unknown or a poor functional capacity. And as you can see in the lower left slide, in patients such as ours who have 3 or more clinical risk factors undergoing vascular surgery, it is reasonable to proceed with cardiovascular testing if it will change management. Described here on the next slide is the 3 key factors. Class 2A is good functional capacity. These patients do not need to undergo pre-op testing. Down on the bottom are the patients who need to undergo low-risk surgery who need no further testing. And in the middle are the patients who are at intermediate surgical risk and functional capacity. And those are the ones who need more careful analysis as to what to do. So if you recall, I did not like the word cardiac clearance, but rather call it preoperative cardiovascular evaluation. And upon taking further history, despite her progressive claudication, the patient had a history of exercise intolerance. She described shortness of breath and chest tightness on walking 1 to 2 blocks. This was never evaluated, and symptoms became less apparent as claudication worsened and became activity limiting. Here's her electrocardiogram. The electrocardiogram shows a Q wave in lead 3 with small Q waves in lead 2 and F, and nonspecific STT changes in leads 1 and L and V5 and V6. Certainly not grossly abnormal, but does have some abnormalities that are worrisome for coronary artery disease. So now we really move back into step 2, that this patient may have active cardiac condition and needs to be evaluated according to a different algorithm. The next slide shows the Diamond-Forrester risk assessment chart of chest pain. That is, assessment of chest pain by age, gender, and nature of the chest pain, which is typical angina, atypical or probable angina, or non-anginal chest pain. And in this case, this woman fits into intermediate to high category, the bottom line, depending on whether you call her typical angina or atypical angina, but certainly at significantly increased risk for having coronary artery disease. The next slide demonstrates the appropriate use criteria for imaging in the symptomatic patient. And in this category, you could see that a variety of tests are appropriate in a patient who has high pretest probability of coronary disease, EKG that is non-diagnostic, and has inability to exercise, in this case due to her peripheral vascular disease and claudication. That certainly stress radionuclide imaging in this particular situation would be appropriate if she had immediate pretest probability, high pretest probability. And so based on that, stress myocardial perfusion imaging with pharmacologic stress testing was carried out. And what you could see here is a markedly abnormal stress test. The top two lines are the short axis views. The middle two lines are the vertical views. And the bottom two lines are the horizontal views. The top line in each grouping is stress, and the bottom line is rest. And what you could see here is a large perfusion defect involving the lateral wall that partially reverses. In addition, there is a defect of the inferior wall that partially reverses, and a small anteroapical defect, an apical lateral defect that reverses, suggesting advanced and severe coronary artery disease. Looking at some of the more quantitative assessments on the next slide, we can see that she has high-risk markers. She has a sum stress score of 20, which would put her in a high-risk category of a large amount of ischemia, and she has a TID, or transient ischemic dilatation ratio, of 1.36, suggesting that the heart appears to dilate on stress due to a reduction of global subendocardial blood flow. So now we have a whole different perspective on how to evaluate the patient. We have a patient with known diffuse vascular disease, peripheral vascular and coronary. Symptoms of angina that were significant were masked by other symptomatologies of peripheral vascular disease, but she has a high-risk myocardial perfusion scan. And in that case, coronary angiography was appropriate. She underwent coronary angiography, which revealed severe triple vessel coronary artery disease. Subsequently, she underwent successful coronary bypass. Following recovery from her coronary bypass, she underwent successful peripheral vascular surgery. She had a good recovery, and she did well in cardiac rehab without angina, shortness of breath, or any signs of claudication.
Hi, this is Andrea Medina, MD, PhD, Assistant Professor in the Department of Medicine, Section of General Internal Medicine at the University of Oklahoma Health Sciences Center in Oklahoma City. I want to discuss some highlights about this case from the perspective of a primary care provider. First, we should review the 4 diagnostic categories for cardiovascular disease, these being coronary heart disease, cerebrovascular disease, peripheral arterial disease, and aortic atherosclerosis and abdominal or thoracic aortic aneurysm. Cardiovascular disease affects most Americans over the age of 60, and so this is an entity we are very familiar with in an outpatient primary care setting. Risk factors for cardiovascular disease include hypertension, diabetes, dyslipidemia, smoking, chronic renal disease, a family history of early atherosclerotic disease. Of these, diabetes and smoking carry a higher relative risk for peripheral arterial disease than coronary artery disease, although the other risk factors I mentioned still remain major risk factors for both. Patients with PAD often have coronary artery disease, and patients with both have a higher risk for MI, stroke, cardiovascular-related death, and all-cause mortality when compared to patients with PAD alone. Cardiac symptoms can often be masked by other comorbidities. For example, shortness of breath in a patient who smokes and has COPD, or a patient who had symptoms of claudication due to peripheral arterial disease. As illustrated in this case, it is important to get a thorough history and not attribute symptoms like exercise intolerance or shortness of breath to other disease processes in a patient with coronary artery disease risk factors. Keep in mind that about 55% of patients with severe lower extremity PAD, like the patient in this scenario, also have significant coronary artery disease. All-cause mortality for combined lower extremity PAD and CAD is approximately twice as high as that resulting from either of the individual conditions. As Dr. Wolinsky discussed, as primary care physicians, we are often asked to provide cardiac clearance for our patients. And while we cannot clear anyone, as every procedure has risk, and no one can be cleared from risk, we can provide an estimation of risk, and we do this often. Not every patient will require preoperative testing. Refer back to the algorithm in this case. based on the ACC guidelines for a non-emergency surgery in a patient without acute coronary syndrome who has low perioperative risk of adverse cardiac events, you can proceed without further testing. If the patient has a high perioperative risk of cardiac events and a moderate, good, or excellent functional capacity that is met greater than 4, then proceed without further testing. As an aside, in determining low versus high perioperative risk, I like to use the revised cardiac risk index, or RCRI. A score of 0 to 1 indicates low risk. And you give the patient 1 point for each of the following: a creatinine over 2, heart failure, insulin-dependent diabetes, suprainguinal vascular surgery or intrathoracic surgery, history of stroke or TIA, and known ischemic heart disease. There are other risk calculators that you can use as well, like the American College of Surgeons NSQIP surgical risk calculator, or the other calculator from the American College of Surgeons, often referred to as the Gupta perioperative risk calculator. After you know the risk, high or low, remember that it is the high-risk patient with unknown or poor functional capacity, that is 1 to 3 METs, in whom you would consider testing. In this patient, given the history of peripheral arterial disease and high prevalence of coronary artery disease in patients with peripheral arterial disease, in addition to him having active chest pain, preoperative testing is appropriate because it could change the outcome of the surgery, as it did in this case, with the patient having a positive stress test, followed by coronary angiography, then coronary artery bypass surgery, and only then getting the peripheral vascular surgery. Thank you for your time.